prednisone, which is a very powerful and awful drug for many, if someone's having a really bad episode or flare, especially like a frozen shoulder, if anyone knows, they're like really, really painful. But if you can catch it early and inject with cortisone or prednisone, it can really shut the whole process down. Otherwise, it's 18 months of trouble. Like it's 9 months of getting worse and tighter and stiffer and more painful, and 9 months of getting better. And sometimes there's still a little loss of range and sensitivity even after that. So, but if you can catch it early, the prednisone tends to help with mast cell activation and shut it down. So that's a terrible but good thing to do.
Is that only for shoulders?
No. So if someone has, like a real bad onset of any joint pain or injury, or irritation, like we're a little more likely to be benefited by like hit it hard and shut it down. Especially if there's a history of like, I have this thing and then I'm down for months of pain.
Right.
That being said, a lot of people can't tolerate prednisone. It's really intense. It can cause all kinds of awful side effects. And you don't want to be on it long term either, because it's got really bad things it can do over time. So there's a local doctor here who we're hoping to have come speak in the summer. Her name is Christine Salter-Price. She's an MD who's duly trained as an allergist and an immunologist. She knows about mast cell activation syndrome. She studied with Dr. Afrin, who was one of the national leaders in that area, and she takes it very seriously in the EDS population and screens all of us for it. So I send all my EDS patients now to her, at least for screening. So you can be on much lower key meds on a daily basis to prevent flares. And things like chromal and sodium, catotofen and singular tend to be the first line of defense. And all things she said that she would put an infant or a pregnant person on. So, but then if there's a big response, hitting it hard with prednisone and maybe aspirin. There was a doctor that spoke at the EDMAP conference, Dr. Maitland, who talked about some mounting research that maybe aspirin actually had some buffering effect for mast cell. That being said, some people are allergic to aspirin, or horrible response to it, so I can't prescribe this stuff, but it's stuff to ask your doctor about.
So with prednisone, can they use a lower dose than they normally do when they're trying to like work with a joint?
It probably would depend. Different people have different abilities to metabolize certain drugs. Some people metabolize them too fast, some metabolize them too slow. So a lower dose may not be the answer. It might actually be a higher dose for some people, depending on where they're at in that spectrum, if their body can metabolize it or not. And there's a great test for how to metabolize. One of the companies out there is the Genelex Corporation. The test is called uscript.com, and they take a swab of your saliva and send it off for genetic testing to see if you're a slow or a fast metabolizer of certain drug categories. Yeah, they tend to definitely do all the antidepressants and anxiety medications, and then there's a few other anti-inflammatories in there that they test. So, one of the docs at the conference said that 50% of people with EDS have a problem either too fast or too slow. So if you've had trouble with medications not working for you, having reverse effects or that kind of a thing, it might be worth pushing to get that tested. It's really expensive again, so again, making the case that like 50% of us have this problem, I've had these problems in the past, this is why I should be tested. And trying to embark on anti-anxiety or antidepressant medications when you've had massive horribleness happen when taking them is a really scary proposition for someone who's already anxious and depressed.
Yeah.
So knowing that it's the right thing can really instill a lot more confidence in moving forward with the treatment plan. I should have put a slide up on this. This is my own finding. I did talk in a group with Dr. Graham and Dr. Maitland about this at the conference. Patients with EDS that are in that second phase, the pain phase, or the third phase, which was the stiffness phase, there tends to be a kind of a whole body pain. That's oftentimes called fibromyalgia. Not always, but sometimes can give them that diagnosis. So getting on the proper medication regimen to help with neurochemistry is really critical, getting that pain gone. What I've noticed is with my patients, once that pain's gone, then we tend to have joint-specific pain. So it's like my this hurts, my that hurts. It just hurts all the time. And I would call that non-mechanical pain. It's like, you're not moving, why is it hurting? It still hurts, right? It still hurts, right? That's not a mechanical problem. So it's not really a PT problem yet. And so my guesstimation, and in talking to Dr. Maitland, she's like, I think you're absolutely right, that that's mast cell activation in the joint. And so treating the inflammation and some of the other byproducts of the mast cells coming to that area can be really important to getting that pain down. Then we have mechanical pain under that. And so then it's like, well, I feel it when I do this. It's like right there it hurts, right there it hurts. But when I'm not moving, it doesn't hurt. Or if I've moved a lot, then it hurts all night because I've inflamed it. But otherwise, it doesn't. That's more mechanical pain. And that's more of a PT pain, you know, where we can teach different mechanics. We can try to retrain how the muscles work. We can teach you to avoid certain positions and that kind of a thing. So there tends to be layers to the pain. And so if I just try to treat the mechanical pain and the whole body-wide pain is there, it's going to be a really slow, hard road. We are going to make some progress, though. You know, so I really recommend getting that approach of like going to see someone to talk about the neuropsych stuff, going to talk to someone about the mast cell inflammatory piece, which could be a rheumatologist, it could be Dr. Price, like the allergist immunologist, and then seeing your PT for the other pain. Or possibly then having a regimen of meds that are for that sudden onset of pain from overactivity, like, you know, hydrocodone or morphine or something in the cupboard that you can use for like a spike that you just like, I gotta get to sleep. Because the sleep's really, really important. Yeah. And so I'm not like I don't love medication, but there's certain things that it really, really helps. So the mechanics of stretch. So why is stretching important? So this is my pedestal that I'll get on. It's a little different than the PT that talked at the doctor's conference. Is that by doing a gentle stretch, it aligns the fibers of the collagen in it. When we lay scar tissue down, which is stimulated as a healing response to overstretch or mast cell activation, the body just lays it all randomly. It's all kind of every which way. But what we want is for that scar tissue to be aligned in the direction that we need it in. So if we stretch it this way, the fibers will sort of realign in that direction. And so a 3 to 5 second stretch is gentle is enough to get them to know which direction you want them. So that's really helpful, especially if someone's in a high pain state. They haven't gotten on the neuropsych meds, and so their body's going to feel any kind of flicker of anything as a pain thing and set off a huge pain response, which is going to include more inflammation and more pain, and more cortisol, and more stress chemicals, and less sleep, right? So 3 to 5 seconds is short enough that it has not stimulated the chronic pain fibers to fire. The chronic pain fibers are a cumulative fiber. It takes like boom, pain message. So it takes a while to go. There's shorter acting pain fibers, alpha fibers, that sensory fibers that it's like, oh, I feel something. And that's in that 0 to 3 second range. So if someone's really sensitized, we keep it short, keep it brief. It takes about 90 seconds though to get a myofascial stretch. So let's say someone has developed stiffness in an area because of myofascial scarring. It takes 90 seconds for it to actually, what do you see? Question?
I don't know what
myofascial means.
Yeah, I don't know what that's
What that means. Okay. So back to the chicken analogy. So when you take the skin off the chicken and there's white stuff, there's two kinds of white stuff. There's like the fuzzy white stuff that kind of holds the skin to the muscle, but then there's the shiny stuff that's over top of the muscle.
Right.
Both of those are different kinds of fascia.
Okay.
Okay, and so they are encasements so they're encasements for the muscle, but then if we look under a microscope, there's encasements for portions of the muscle, and there's actually an encasement for every single muscle cell. So think of it like a honeycomb.
I had experience with that.
Yeah.
So yeah, I know,
Yeah.
yeah.
And so you can get scarring where the fibers are supposed to line up in the direction of the muscle, you know, and maybe there's some crosswise in case the muscle gets flattened out for some reason, or the muscle tenses and bulges, so you want something to prevent it from just bulging right on out.
Mm-hmm.
But you also want some in case the muscle gets stretched. So you want the fibers to be lined up in those directions that support and help the muscle. But let's say now we've glued the skin down to the muscle so that every time you contract the muscle, the skin pulls and it starts to rip on the fascia. There's this huge pain response that happens before you've even felt it. So you haven't even felt the pain yet, but your body has mounted this big response. So if in an area of your body where you've had a lot of chronic pain, you could just try to lift the skin there. If it feels like you're ripping your skin off, you've got myofascial restrictions. So
Okay.
the low back is a good one.
So is the 90-second release the same as Dr. Jones' strain, counter strain?
It is, and so great point. So she's talking about Dr. Jones, who is a osteopath, I believe, right? Now dead.
The son.
His son's doing it? Okay. who teaches a class on how to shorten the muscle. Usually, you're shortening the muscle to relax it so that it doesn't contract. But it's called strain counter strain because when you shorten a muscle on one side of the joint, there's another muscle on the other side of the joint that's getting lengthened. So it's possible that this is the victim. It's hurting and it's tender because this is really tight and it's pulling, and you can even see my skin as I pull from the back, it's tight in the front. And so if I can shorten the front and make the back stretch, I rebalance that system. And so yeah, there probably is some fascial resetting that's happening in that strain counter strain technique in a very gentle way. You're using what's the tender point, and then you're trying to slacken the tender point so that it's not being pulled on anymore, and you make the real guy do the job. So that kind of treatment tends to be very effective with people with EDS, and other forms of myofascial release, craniosacral therapy, tend to work really well. So stretching actually can reduce pain. In the muscle itself, the muscle, if it's been in pain, really bad pain for a long time and hasn't been used very effectively, can develop a thing called a ragged red cell. Sounds terrible.